Let's see an NCLEX RN video based on care of patients with immune disorders. So you know that immune disorders are mainly classified into two. They are the primary immune dysfunction, that means they occur in persons who are born with an immune system deficiency or ability of dysfunction in the immune system. That is primary immune dysfunction. This primary immune dysfunction can be because of B cell deficiency, T cell deficiency, or because of both these cells deficiencies that is present at the birth. Then there are secondary immune dysfunction, which is also known as acquired immune deficiency, which occurs when there is a damage which is caused by an external environmental factor. For example, if you see like exposure to certain medicines or chemicals or some other disease conditions result in secondary immune dysfunctions. So in this video we will be seeing the different types of immune disorders and how to take care of the patients. First question, when assessing a patient with Digeorge syndrome, expected findings include which of the following? Select all that apply. Cleft palate, recurrent infections, hypocalcemia, cardiac abnormalities, frequent fracture history. So here you need to know about what is Digeorge syndrome. I told you the primary immune dysfunction may be because of T cell deficiency or B cell deficiency or both. So this Digeorge syndrome is an example for T cell deficiency. It is a primary immune dysfunction, that means that is congenital. It is known as congenital thymic hypoplasia also. It is an autosomal dominant genetic condition that arises from the 22nd chromosome. It is an autosomal dominant. Autosomal dominant means that the presence of only one altered gene is required for the disease to be present. The disorder arises spontaneously and is present at the time of the birth. If you know a little more deep about this Digeorge syndrome, you will find that it arises from the disturbance of the normal embryological development of the pharyngeal pouches. These pharyngeal pouches, they develop during the 6th and 10th week of gestation. These pharyngeal pouches are the embryonic precursors to specific organ systems in the head, neck and chest. The 3rd and 4th pharyngeal pouches, they develop into thymus, parathyroid gland and aorta, and the 6th pharyngeal pouch is for the pulmonary artery. The effect of this Digeorge syndrome is dependent on which pharyngeal pouch is affected. But typically we can see the dysfunction of the thymus gland, parathyroid gland, facial deformities such as cleft palate you can see, and heart anomalies. So the thymus gland is mainly affected. The thymus gland, it is responsible for T cell production as well as differentiation. So when thymus dysfunction result, T cell deficiencies will occur. Then if T cell deficiency is there, you know that T cell help B cells to mature. So in turn it will later on result in B cell activity also will be reduced at that time. Mainly if we are seeing the clinical manifestations of Digeorge syndrome, frequently infections you can see in this patients, then Candida albicans, which is almost always seen in patients with T cell deficiencies, then other deficiencies. If we are seeing the acronym CATCH, we will understand that C is for cardiac anomaly, especially tetralogy of Fallot you can see. Then abnormal phases, that is A. T is for thymic aplasia, C is for cleft palate, and H is for hypocalcemia. Hypocalcemia is because of hypoparathyroidism. And it is known as, this acronym is known as catch-22 because the 22nd chromosome is affected in DiGeorge syndrome. So from this acronym we will be able to answer this question. So cleft palate we can see, recurrent infection you can see, hypocalcemia and cardiac anomalies. Hope you understood this. Second one, the nurse monitors for which clinical manifestation in the patient diagnosed with X-linked agammaglobulinemia, XLA. So here you need to know about this XLA. So you need to know about this X-linked agammaglobulinemia. So whether it will be having a drooping eyelids, chronic sinus infections, hypothermia or cleft palate. I will tell about XLA. So XLA is mainly because of B cell deficiency. It is an example of B cell deficiency. B cells, you need to know, they are involved in the production of humoral immune response. Humoral immune response means the antibody response. An antibody or immunoglobulin, you know that it is produced in response to a foreign substance which is known as an antigen. So when this B cell deficiency will occur, the B cell precursors will not be able to make the B cells mature, and B cells can't be seen in the plasma cells. So in this X-linked agammaglobulinemia, this is a X-linked recessively inherent disease. It is also known as congenital primary immune deficiency of B cells. If it was of the T cells, it is DiGeorge syndrome. And X-linked agammaglobulinemia primarily affects male because it is unlikely that the females will inherit two X chromosomes carrying the altered gene. This is X-linked recessive. That means if there is one X chromosome, and that is particularly for the males, they are having one single X chromosome, and if that is affected, then of course they will have the symptoms of the disease. Females has got two X chromosome, and if it is very rare that both of the X chromosomes will get the particular gene, then they will be affected. Here mostly the females, only one X chromosomes will be having this altered gene, so usually they are carrier of the disease. Females are carriers and males are the persons who are having the disease for XLA. And this XLA, it is also known as Bruton's agammaglobulinemia. That is, there is because of the maturation of BTK gene, there is a problem. BTK means Bruton's tyrosine kinase. This is a particular thing which is required for the development of B lymphocytes. So this Bruton's tyrosine kinase, BTK gene has got some problem. So this Bruton's tyrosine kinase that is not produced, or deficiency is there, the B cells, they are not developed, or there is some problems with the B cells. So they can't produce the antibodies or immunoglobulins. When these B cells can't produce antibodies, when antigen is invading, the patient will get infections. The clinical manifestations can be infections, any type of infections, particularly of ear, lung, skin, conjunctiva, or the central nervous system. And recurrent bacterial infections you can see of the respiratory tract in childhood, and chronic respiratory infections such as sinus infection, pulmonary disease are all common with this XLA. And patients will be getting recurrent pneumonia, meningitis, septicemia. There may be autoimmune diseases like leukemia, lymphoma, and also susceptible for viral infections like hepatitis, polio, enterovirus. So more chances of infections in patients with XLA. And if we are talking about the treatment, we have to give IV immunoglobulins because the antibodies are contained in this IV immunoglobulin. So here the question is asking, what are the clinical manifestations of the patients with XLA? The answer is chronic sinus infections. Next question. The nurse includes which information in the teaching plan about the management of primary immune disorders? Infection monitoring blood test, 10 warning signs of primary immune disorders, bone marrow transplant, precautions to prevent infection. So now primary immune disorders, you know that at the time of birth itself the patient has got this condition. It is congenital. So blood test and all, it is required, but it is not the main teaching plan about the management. In the management you have to really prevent the infection. They are more prone for infection. So precaution is the one thing which you need to include in the teaching of management of the primary immune disorders. In this slide I would like to add one point about the 10 warning signs of primary immune disorders, which include, first one is 8 or more new infections within 1 year. Second one, 2 or more serious sinus infection within 1 year. Third, 2 or more months on antibiotics with little or no effect. Fourth one, 2 or more pneumonias within 1 year. Fifth one, failure of an infant to gain weight or grow normally. Sixth one, recurrent deep skin or organ abscesses will happen. Seventh, persistent thrush in the mouth or elsewhere on the skin after age 1. Candida infections are more common. Then 8th one is need for IV antibiotics to clear infection. 9th, 2 or more deep-seated infections. And 10th one, a family history of immune deficiency. So these are the 10 warning signs of primary immune disorders. Graves' disease is an example of which type of hypersensitivity reaction? Is it a type 1, type 3, type 4, type 5? So here you need to know about the different types of hypersensitivity reaction. So hypersensitivity reaction is when the immune response is overactive to a foreign antigen. An antigen, you know, it is a foreign protein that stimulates an immune response in a susceptible individual. Mainly, there are 5 types of hypersensitivity reaction: type 1, type 2, type 3, type 4 and type 5. So this particular disease and their particular hypersensitivity you need to know. Graves' disease is an autoimmune disorder that is a result of type 5 hypersensitivity reaction. So Graves' disease, type 5. Then there is something known as the systemic lupus erythematosus or SLE. That is because of type 3 hypersensitivity reaction. Then another one is Goodpasture syndrome. That is because of the type 2 hypersensitivity reaction. And here I would like to add one more point. Type 1 hypersensitivity reaction is not manifested as autoimmune. Really allergic reactions you can see in this type 1 response. So here Graves' disease is related to type 5 hypersensitivity reaction. Let's see one slide, the different types of hypersensitivity and examples. Type 1 is known as, it is an immediate rapid allergic reaction. For example, the allergic rhinitis, asthma and anaphylaxis you can see with this type 1. Type 2 is a cytotoxic reactions like blood transfusion reactions, Goodpasture syndrome, autoimmune thrombocytopenia, thrombocytopenic purpura, then myasthenia gravis. So they are coming under type 2 or cytotoxic reactions. Then third one is immune complex reactions. So there comes systemic lupus erythematosus, rheumatoid arthritis, serum sickness. Type 4 is delayed hypersensitivity reactions or T cell mediated. Contact dermatitis to poison ivy, positive TB skin test and latex allergy comes under type 4. And type 5 is stimulated. Graves' disease and B cell gammopathies we can see in type 5. Let's see a little more detail about this type of hypersensitivities. Type 1 hypersensitivity. It can be local reactions or systemic reactions you can see. The local reactions like allergic rhinitis, hay fever, they are local. And the most severe form you can see is the anaphylactic reaction. That is a systemic reaction you will be observing with type 1 hypersensitivity. So this is quite immediate. What happens is that the first time a patient is exposed to a particular allergen, can be a food or dust or pollens, whatever, then at that time IgE is produced. That is the antibody which is produced. This IgE antibodies, they will attach to the mast cell. So next time when the patient is exposed to the same particular allergen, this IgE antibodies already they are attached to the mast cells. This causes the mast cell to degranulate. That means they will open up, that granules will be coming out, releasing a substance known as histamine. The mast cell will release histamine and also other chemicals like leukotrienes and prostaglandins, which result in smooth muscle contraction, vasodilation happens, increased vascular permeability will happen, bronchoconstriction happens, edema will result. So these are the symptoms of allergy which will happen when the same allergen is exposed the second time. So this is type 1 hypersensitivity reaction. The mainly eosinophil count will be more. The normal count, you know that it is 1 to 2%, but here the eosinophil count will be more with type 1. And the treatment depends on the severity. Diphenhydramine hydrochloride, known as Benadryl, it's an antihistamine. Histamines are released, now antihistamine we are providing. That will decrease the edema and the construction of smooth muscles in the respiratory tract and blood vessels. And steroids may be indicated to decrease the inflammatory response and also to decrease that mast cell degradation. Then beta agonist bronchodilators help in easing the respiratory distress which is caused by the respiratory smooth muscle relaxation. So these things we will be providing. The second type of hypersensitivity reaction, which we are calling it cytotoxic reaction. So here especially this erythroblastosis fetalis and this blood incompatibilities, RH incompatibility or ABO incompatibilities, you can see mainly with this type 2 transfusion reactions we can see. You know that when a RH negative mother marries a RH positive father, they are having a child, and the first child, if the first fetus is RH fetus, RH positive fetus, the mother is RH negative, the mother is carrying a RH positive fetus in the body. Then RH antigens from the developing fetus can enter the mother during the delivery time. Mother's blood, it enters. This Rh antigens will enter. In response to the fetal Rh antigen, the mother will produce anti-Rh antibodies. If the woman becomes pregnant with another Rh positive fetus, her anti-Rh antibodies will cross the placenta and damage the fetal RBCs. So this is known as erythroblastosis fetalis. It happens. And also blood transfusion reaction. You know that a person with type A blood group, they will have A antigen. A group means A antigen they are having and anti-B antibodies. Person with type B blood has B antigen, anti-A antibodies. AB blood group has both A and B antigens and no antibodies. O has got no antigens and both anti-A and anti-B antibodies. So, patient should receive matching blood types. Otherwise, there will be reactions which will happen. Type AB is called universal recipient. They can accept because they lack both this anti-A and anti-B antibodies are not there. But O blood group is called universal donor because they lack antigen. If patient receives this incompatible blood, the patient will complain of chills, fever, pain, heat sensation at the transfusion site. Rash may develop. Antibodies causing agglutination or clumping will happen, and the blood vessels clumping blocks the blood vessel, results in ischemia and all. And later on it result in the vascular spasm in the kidneys. It will block the renal tubules, resulting in renal failure and all. The cytotoxic reaction happen with this antigen antibody interactions. This Goodpasture syndrome is an autoimmune disease in which the patient's immune system attacks the Goodpasture's antigen, that is an antigen in the glomerular basement membrane. So that is about Goodpasture syndrome. Then in myasthenia gravis, it is also autoantibodies to acetylcholine receptors on the neuromuscular end plates are formed. These autoantibodies either block the action of the acetylcholine or mediate the destruction of the receptor. So in both these situations, it leads to decreased neuromuscular function and weakness. Then moving to the type 3, that is immune complex reaction. That means immune complex, that formation of antigen antibody complexes will happen. This type 3 also is categorized into systemic and local reactions. Systemic reactions include this rheumatoid arthritis, then SLE, serum sickness, and this local reaction includes this Arthur's reaction. Arthur's reaction immediately after vaccination and all, you will develop vesicles and red raised lesions you will be seeing at the site of injection. That is the development of this antigen antibody complex. That is a local reaction after the BCG injection, vaccination and all, you can see that. The other three, the SLE, rheumatoid arthritis and serum sickness. So here this antigen antibody complex are developing. These immune complexes are large molecules of antibody combined with antigen, and because of their size, the body is having difficulty in removing it from the body. The diseases are resulting when they are not removed but they lodge in the tissues. That is this problem with this antigen antibody complex. This immunoglobulin G is the immunoglobulin which is involved in this type 3 immune complex reactions. Particularly in rheumatoid arthritis, you know that these complexes will be lodged in the joint spaces. In SLE, these antibodies against virtually any organ or tissue can happen. It can lodge in the vessels, cause vasculitis. It can lodge in the glomeruli. This complex can come and lodge in the joints also. If it is in the glomeruli, that causes nephritis. In the joint, it causes arthralgia and arthritis, and also it affects the connective tissue and multiple organs, resulting in cardiovascular, renal or neurological complications also. So then coming to the type 4. Type 4 is a delayed hypersensitivity reaction. It is T cell mediated. T cell mediated and here it is more related to the cell mediated immune memory response. It is not related to the antibody. It is related to antibody means it is B cell mediated. Here it is not related to the antibody. It is cell mediated response. Example is this contact dermatitis to IV, poison ivy, and positive TB skin test and latex allergy. And the last one, the type 5, here it is stimulated. This type 5, it's an antibody mediated cellular dysfunction only. It is not cell mediated, but it results in change in the cell's function. Something which is similar to type 2 hypersensitivity reaction only. But here cell death will not happen, but the functions of the cell is changed. That is why it is known as the stimulatory reaction. The excessive stimulation of the normal cell's surface receptor happens. Best example is the Graves' disease. So in Graves' disease, it is a form of hyperthyroidism. Continuous stimulation of the thyroid cells to produce thyroid hormone will happen. The normal feedback mechanism is no longer working. The thyroid gland is normal, but it will exhibit the features of hyperthyroidism. So these are the different types of hypersensitivity reaction. The nurse in a medical surgical unit has assessed several patients. It is a priority for the nurse to first follow up on the patient who has which of the following: a fever of 100 degree Fahrenheit, a blood transfusion that was just initiated, a third IV dose of antibiotic infusion, or pulse oximetry of 93%. Of course, immediately after blood transfusion, there is a chance of anaphylactic reaction. So blood transfusion, we have to monitor. The nurse have to do a follow-up for any type of reactions. The nurse is screening patients for the risk of developing gamma globulinemia or XLA. The nurse should consider which patient at greater risk: a 6-year-old female without any family history, a 35-year-old female with a respiratory infection, a 7-month-old male with recurrent infections, a 40-year-old male with a family history. So when you read about XLA, it's a primary infection. Primary means it is present from the birth until 6 months. Mother's antibody is ready to protect the child. There won't be any infections much in the first 6 months, but later on there are more chances of infections for this particular child. So a 7-month-old male with recurrent infection is at risk for this development of XLA, a gamma globulinemia. So screening should be done for that patient. The nurse monitors for which clinical manifestation in the patient diagnosed with XLA: low temperature, recurrent respiratory infections, low BP, diarrhea. It's already told SLA has got recurrent respiratory infections. The nurse is caring for a patient with Digeorge syndrome. Precautions are taken for decreased level of which of the following: B cells, thyroid hormone, serum calcium, serum iodine. So in Digeorge syndrome, when you read about that acronym Catch-22, you understood there is hypocalcemia. So serum calcium is one thing which will be decreased. It's a problem with T cells and not B cells, and the thyroid hormones and serum iodine is not affected. What is the desired therapeutic effect of the calcium supplements for the patient with Digeorge syndrome? Is it to improve the muscular contraction, to prevent the tetany, decreased heart rate, or increased bowel sound. So in Dijon syndrome, there is more chance of having a tetany and seizure. So we are giving calcium supplements to prevent that. The nurse correlates low level of IgG with which disorder? Is it selective IgA deficiency, CVID, HIGM syndrome, IgG subclass deficiency? So here we will learn a little bit more about each of this. HIGM, that is hyper IgM syndrome. It is a X-linked immunodeficiency where low level of IgG and IgA serum level, and there will be a normal or high level of IgM and IgD. So here the question is asking low level of IgG. So it is seen in this HIGM syndrome, hyper IgM syndrome. And the other thing, let's see, the next is the common variable immune deficiency. Common variable immune deficiency is a category of B cell deficiency. This HIGM syndrome is a T cell deficiency. This CVID, common variable immune deficiency, is a B cell deficiency due to the lack of differentiation of B cell into the plasma cell. The CVID happens. Low level of circulating antibodies will be present in our body. There are normal level of B cell, but they fail to differentiate into antibody secreting cells in CVID. Then this selective IgA deficiency, it is also a B cell deficiency and it is quite common type of immunoglobulin deficiency. IgA is less, selective IgA, and the IgG and IgM levels are almost normal in that. The last one, IgG subclass deficiency, that is also a type of B cell deficiency, but selective IgG will be deficient, not overall. So the answer is HIGM syndrome. So here Smith, a patient 50-year-old male, presents with a temperature of 101 degree Fahrenheit, productive cough, fatigue, difficulty breathing. He has a history of seasonal allergic rhinitis and mild asthma, but no other significant health history. He does not report any non-medication allergies. Mr. Smith's chest X-ray reveals pneumonia. He is placed on IV penicillin. The nurse returns to check on the patient and finds he is short of breath and extremely anxious about his symptoms, and states that his skin is itching and he feels dizzy. Upon initial assessment, his pulse is rapid, his lips are blue tinged, a rash is apparent on his chest and arms, and wheezing is heard on auscultation of his lungs. The patient expresses a sense of impending doom. Vital signs at this time are BP 85-50 mm of Hg, heart rate is 130 beats per minute, pulse oximetry shows 89%. So what we can understand is the patient came to the hospital, and when IV penicillin was given, the patient started with certain symptoms. So these are example of anaphylactic reaction has happened for the patient. So the patient complains of severe dyspnea and shortness of breath. Itchy skin wheals or hives have spread over his body, it forming large red blotches. The nurse immediately, what she does is discontinues the IV penicillin, the IV tubing is changed, and normal saline is initiated. Then epinephrine 0.5 mg is administered IM stat. Oxygen therapy is provided via a 100% high flow non-rebreather face mask. Oxygen saturation improves to 90% after the initiation of oxygen. Diphenhydramine 50 mg is administered via IV push and IV fluids are initiated. Then albuterol, a beta agonist, is administered via nebulizer to relieve the bronchospasm. Emergency equipments for ET intubation and possible tracheostomy is readied, and Mr. Smith's condition now begins to improve. So this is a typical example of anaphylactic reaction after medicine administration. This is a type 1 hypersensitivity reaction which you have observed in this patient. Let's see some questions. The nurse caring for Mr. Smith, who is having an anaphylactic response to penicillin, incorporates which nursing diagnosis into the plan of care? Risk for ineffective gas exchange, risk for hyperventilation related to anxiety, pain related to bronchospasm, knowledge deficit, prevention and treatment of anaphylaxis. So when a patient is having an anaphylactic reaction, the patient has difficulty breathing, bronchoconstriction and edema that lead to risk of ineffective gas exchange. So risk for ineffective gas exchange is the priority nursing diagnosis. Hyperventilation and pain may occur, but it is not the priority, even knowledge deficit. The priority nursing assessment for the nurse caring for Mr. Smith is assessing bowel sound, a full head-to-toe assessment, monitoring respiratory status, assessing the skin for a rash. Of course, the nurse has to monitor for the respiratory status. The nurse caring for Mr. Smith understands which of the following is the priority intervention when noting he is having a reaction to the penicillin infusion. Contact provider for orders, ready emergency medication, discontinue IV penicillin, discontinue IV completely. The first thing the nurse need to do is to discontinue IV penicillin and the tubing to be removed. Start with normal saline, then contact the provider, arrange the emergency medications. So there should not be discontinuation of IV completely. The nurse understands that Mr. Smith is having a potential allergic reaction by which of the following symptoms? Generalized fatigue, tachycardia and hypertension, abdominal pain and nausea, hypotension and tachycardia. So here the reaction is hypotension and tachycardia. With this allergic reaction you can see the tachycardia with hypotension. The nurse monitors for which complication in the patient with progressing anaphylaxis? Circulatory failure, seizures, bradycardia, hypertension. So the worst complication following this anaphylaxis is respiratory failure as well as circulatory failure. So here the answer is circulatory failure. Hope you understood with this video. Thank you so much.